exam going PGs that before COVID, it was live patients who were given for examination, like you do it during your undergraduate days, asking all the complaints from the patient, then asking for the detailed history, how it started, how it progressed, and then going for physical examination, and then thinking about what are investigations needed for your confirmation of your probable diagnosis. And then the case discussion will start with the examiner, and they go through this series of steps to assess your knowledge about that particular patient. It was broken in between due to COVID pandemic. Students were not given live patients, case scenarios was presented, and then gradually they are now reverting back to the old system of giving live patients for you. In fact, the last batch of mine who were attending my classes in Chennai, they had exam centers in different states where language was a problem and the translators were not provided. So with all these difficulties, they were asked to examine the patient, record all the history, and then go through the detailed other points and then present the case in a live safe manner. So this is going to come back, and that will be the pattern. And what I was told that the same case is given to all the students in the exam center. Earlier, they used to be different cases for different students. But now the pattern has changed. They are giving, for example, if they keep one thyroid, one COPD, and one liver case, the same 3 cases have to be examined by all the students, and questions will be asked to assess the knowledge, because probably they think that there should not be any disparity. One should not get an easy case and one should not get a difficult case. So that is probably the idea of the examiners, to have the same case for all of you. So suddenly when they were caught up with this live patients, because in class discussions we go through only by case scenarios all this time, I found that students were finding it difficult because they have forgotten the methodology of how to examine, how to elicit the history, how to examine all these things have become a little bit remorse, and they have not be able to do it easily. So what I thought was, let Anish present his case, first the complaints, then go through the systematic examination, and we will question him in between. So first part, you start with the patient's complaints, then we will, as you narrate the history, we will have a break in between, and then I will start asking the questions. Then once you say this is your probable diagnosis from the history, and then what investigations you want to do to confirm the diagnosis, we will again interfere there, and then we will question you in that. Then what are all the clinical examinations you will have to find, there again we may break. But so that there is no random presentation of all your history, I mean compliance history taking, and then examination investigations. Instead of that, we will have a break in between, and then see how you have to diagnose and then confirm your diagnosis. Then go for the practical discussion of how to manage a patient with CKD if they come for anesthesia and surgery. Okay. So with that introduction, you can go ahead. I think your mic is muted. You can unmute and you can start presenting.
Good evening, sir.
Good evening.
Good evening, ma'am. With your permission, can I start?
Yes, please.
I am Dr. Anish, secondary DMB resident from British Candy, Mumbai. Today, I'll be presenting a case of a CKD patient posted for right ureteroscopic surgery. Chief complaints: a 57-year-old male patient Chandrasekhar, hailing from Mumbai, businessman by occupation. He presented to hospital with history of right-sided abdominal pain since 4 months, on and off, and blood in urine since 1 week. History of presenting illness: Patient was apparently normal 4 months back when he started developing pain in the right flank, which was sudden in onset, very severe pain, often radiates to right back and groin, associated with nausea and vomiting. It gets relieved with pain medications. It is on and off type with a frequency of 2 to 3 times in the last 4 months. Last attack of pain was 1 week back. Patient started noticing passage of reddish colored urine since last 1 week. There is no history of fever, diarrhea, constipation, yellowish discoloration of skin, nausea or vomiting at present. There is no history of lithuria or frothing in the urine. There is no history of reduced urine output or burning maturation. Past history. Patient had similar history 3 years back. He underwent left ureteroscopic surgery 3 years back. Patient was told to have involvement of kidneys secondary to calculi with elevation of serum creatinine and was put on medications. He is non-case of hypertension since 10 years on medications and non-case of diabetes since 12 years on medications. He is not a non-case of bronchial asthma, tuberculosis, drug allergies. Currently, patient is on tablet Ultraset SOS, tab Sobusis Fort 500 mg TDS, tab Febustat 40 mg OD, tab Nefrosave TAD, injection Krebs 40 mics once a month subcutaneous, tab Amlodipine 5 mg BD, tab Glycomet 500 mg BD, and tab Jardiance 25 mg OD. Surgical history, he has underwent left URS with the degestion under GA 3 years back, which was uneventful. Digestion removed after 3 weeks under local anesthesia. Coming to family history, there is no similar history in the family. Personal history, he consumes non-vegetarian diet. His sleep pattern is normal and it's adequate. Bowel habits are regular. Bladder habits, he started noticing dark-colored urine since 1 week. No addictions. On general physics examination, patient
Can
is
you please stop there?
Yes,
before
sir.
you go to the general examination? Now we will have a small discussion on the complaints and history taking now. Okay.
Okay, sir.
Can you go back to the slide where you say patient is a known case of diabetes mellitus and hypertension? Yeah, this is the
Yes,
slide. Now, don't you think you should have asked some more questions about the 10-year duration of hypertension and 12 years duration of diabetes? That
yes,
history is also very, very important because he has two comorbidities apart from the primary complaint for which he has come to the hospital, like hematuria and groin pain. These two are very, very important comorbidities which has been there for quite number of years. So what are all the questions you would like to ask regarding this without examining or getting the history in detail about these two comorbidities? You cannot suddenly go and jump to the physical examination of the patient. So what are all the things you want to know about the hypertension, and
yes.
what are the things that you would like to know about the diabetes mellitus?
One thing, sir, like the duration of hypertension as well as the diabetes. Secondly, I will ask him about like these regular follow-up checkups of for blood pressure and sugar checkups.
Okay.
And what are the medications patient is consuming, and is there any change in the medications or any change in the dosage of medications?
Okay.
Then I'll ask about whether any like complications pertaining to the any of this. Like for example, hypertension can cause like it can cause renal damage, it can cause stroke, it can cause myocardial infarctions, it can cause any like a decrease in the vision and blindness and all. Similarly, diabetes also, I will ask him about the control of sugar, any like occurring of any local infections. Anytime did he have any episodes of hypoglycemia or hyperglycemic symptoms? And does he have any episodes of diabetic ketoacidosis? And also the complications associated with diabetes, like the macrovascular and microvascular complications like peripheral neuropathy, nephropathy, the retinal changes, whether he has undergone any retinal checkups, and whether he has got any like history of chest pain or any, because they are more fun for a silent MI also. So any history of any breathing difficulty, any hospital admissions for the same, and history of any gastric issues, so like they can have more a chance of delayed gastric emptying. So if any chance of aspiration, all those things I will be asking, sir.
Very good. So that is a very, very important thing all the students should not forget about the chronic comorbidities. So I would like to add one more thing is, whenever any chronic morbidity is, the comorbidity is there, you should first of all find out how it was detected in that patient.
Okay.
Now your patient, what is his age? He is about
57.
56.
Sir. Yes, sir.
56, 57. That means he has been detected with hypertension at the age of 46.
Yes, sir.
So what exactly was the complaint with which he was detected to have hypertension? Whether he had a persistent headache, whether he had any giddiness, whether he had any chest pain, or was it found out during a routine medical examination? Nowadays, people have become quite aware of their health and they go for so-called master health checkup every 2 years or 3 years, or when they go for a insurance policy, or when they go for a job, the routine medical examination might have revealed that he is an hypertensive. So what is the difference between a patient who is incidentally found to have hypertension and a patient who has goes to the doctor with a complaint of, say, headache or visual disturbance or giddiness, and then detected to have hypertension? Is there any difference between these two patients?
Yes, sir. Like if the patient is symptomatic and going for doctor, most of the times his blood pressure will be in the higher range, sir.
Okay.
And secondly, he would be going with the with already a secondary changes has happened to the systemic changes would have happened already, and he is
Very
going.
good.
The chance of the prognosis will be accordingly different, sir.
Whereas a patient who is asymptomatic might have recently developed the hypertension. So the secondary complications of hypertension might be quite less in these patients. Okay.
Yes.
So that is very, very important. Similarly, with regard to diabetes mellitus, you should find out whether the patient had symptoms of the classic. Do you get the classical polyuria, polydipsia, polyphagia in a present day diabetic patients?
No, sir.
So what is the presentation nowadays?
Most
Why
of the
diabetes? India is considered as a diabetic capital now because many people are detected to have diabetes mellitus. So what is the reason that the patients are not aware that they are diabetic people?
So most of the patients follow a sedentary lifestyle now without any lack of exercise. And most of them go for routine health checkups. So instantly there are high chances that they can find out diabetes, sir.
Diabetes.
And
second thing is, what about the genetic preponderance? That if supposing a father or mother or brother is a diabetic, so is the patient likely to become diabetic?
yes, sir.
Yes.
Sir.
Family history is a very strong proponent for the patient also developing diabetes mellitus. Okay. So
Okay,
these are the things that you should ask. And in diabetes mellitus, you said about peripheral neuropathy. More than peripheral neuropathy, which particular neuropathy is more important?
Sir, autonomic neuropathy is also important.
Autonomic neuropathy is very, very important, especially a patient with 12 years of diabetes mellitus. And you have got the title today that it is a CKD patient.
Yes, sir.
So can CKD by itself produce autonomic neuropathy?
Yes, sir. CKD associated with the diabetes can produce, sir.
Yes. So both can compound and produce a very bad patient for you to anesthetize and get a good result. Okay.
Oh, yes.
So how will you know clinically whether, or from the history, whether a patient has got autonomic neuropathy or not? What questions you will ask the patient?
We'll ask a couple of questions, sir. One of the symptoms, the patient gets postural hypertension, sir. Usually when they get up from the bed, there is a chance that they can have a giddiness and palpitation, sir. We'll have to ask about the case of any autonomic bladder, sir, whether he has got any passage of urine without without being conscious. And the couple of tests we can do, sir, that includes the heart variability test. In that, we'll ask the patient to lie down, and then we'll ask the patient to get up after 3 minutes, and we'll measure his heart rate after 15 seconds and after 30 seconds. And usually with the hypertension, there will be increase in heart rate will be there, and we'll take a ratio of it after 15 seconds and after 30 seconds. If it is more than 2, that is significant. Then the response to Valsalva maneuver also, we'll ask the patient to take a deep inspiration followed by expiration and followed by deep inspiration again and expiration. So we'll just we see the heart rate variability, and we'll also see for the respiratory sinus arrhythmia. So we'll ask the patients to take a breath of almost 6 per minute, and we'll measure the RR interval. So the ratio of the maximum RR interval and the minimum RR interval will be calculated. So that way also we can make out.
Okay.
And
okay. So these are all more with the ECG only. How you can do all these RR intervals. But Valsalva is the best method to detect it clinically. Asking the patient to breathe against a closed glottis, or it is classically called as a straining during defecation. Okay. So that is the method by which you can increase the intrathoracic pressure and see what is the response. And in a patient with autonomic neuropathy, he will not have an increase in heart rate to maintain the cardiac output, and the overshoot will persist for a longer time in the early stages of diabetic autonomic neuropathy. Okay. So establishing the presence of autonomic neuropathy by asking relevant questions is very, very important, because these patients, when they come and you plan for supposing this URS, what is the plan of anesthesia you prefer?
In our hospital, we do under general anesthesia.
In your hospital, you do this. Whereas many hospitals, they prefer to do it under regional techniques like single shot spinal or epidural anesthesia also. So what is the risk of a patient who is having an established autonomic neuropathy undergoing a regional technique like single shot or epidural anesthesia?
The hypotension produced following the sympathy blockade produced by a regional anesthesia will be profound, sir, and it may not respond to the vasopressors. Vasopressors
like epinephrine or phenylephrine. Okay,
yes,
so that you have to keep in mind. So whenever you think of a regional technique in a patient with established autonomic neuropathy, you have to think twice whether it can withstand and whether a patient can be salvaged, because there have been a lot of incidences where a delayed morbidity and mortality have happened because of administration of regional techniques in the patients with established autonomic neuropathy. Okay? And then the medications. You go to the next slide where you have mentioned the medications.
Yes.
Now, in these medications, what are all the things, what are the indications for these various medications? The Ultracet is a painkiller.
Yes, sir.
It's a combination of, because most of them are in the, it's not in their generic name, it is in the brand name. Okay, so you must know the composition. Because you are working in a private or corporate hospital, everything is given in the brand name. But examiners would like to know the generic or pharmacological name. So for the benefit of those who are not aware of all these generic names of these brands, Ultracet is a combination of paracetamol and tramadol.
Tramadol, sir.
Isn't it?
Yes, sir.
So what is the risk of taking the drug with regard, if supposing this patient has got a kidney involvement also, CKD, as you have, as you know the diagnosis already, is there any interaction with these two compositions in this first tablet of Ultracet?
The elimination will be delayed, sir. Most of the drugs will be paracetamol and tramadol both has got a hepatic and renal metabolism and renal elimination. So patient with CKD has got a reduced clearance of the drug will be, so toxicity of the drug can increase, sir.
Okay. Then what is the thrombosis?
That consists of soda bicarb, sir.
Soda bicarb. Already, this is the conservative management. You skipped earlier saying that he was diagnosed to have CKD 3 years back itself when he came for the right side URS. And at the time they said you manage with medications. So what are all the medications given for the particular problem of CKD that was diagnosed 3 years ago? This one should have been the drug which is advocated for CKD management, isn't it?
Yes.
What is the role of this thrombosis?
The patient
bicarbonate.
CKD patients, most of the times they can tend to have a low sodium level, sir, and the bicarb also helps in maintaining the electrolyte imbalance, sir.
They have an underlying metabolic acidosis. Okay.
Yes, sir.
So to keep it corrected, they give both to correct the sodium level as well as the acidosis. They correct it by giving oral soda bicarb, 500 milligram tablets, thrice a day. Okay. What is fiburic?
Fibustat, so basically it inhibits the usually these patients can have tendency of high uric acid levels, sir. So it prevents an increase in the uric acid level and helps in clearance of the uric acid, sir.
Very good. What is nephrosafe?
Nephrosafe consists of couple of amino acids, sir, which helps in the functioning of the kidney, sir.
It is more or less a dietary supplement. Okay,
Yes.
so it is selective amino acids to reduce the urea level. By giving this nephrosafe selective amino acid, you will help the patient in preventing raising urea levels. So the three drugs, Sobosis, Fiburic, and nephrosafe, are mostly for the CKD management.
Yes.
What about Crest 40 microgram once a month?
It's a erythropoietin, sir.
It's a erythropoietin to prevent anemia. Again,
Yes.
it is a part of the management of CKD, conservative management of CKD.
Yes.
Then coming to Amlong.
It's amlodipine, sir, for blood pressure, sir.
Blood pressure control.
Yes, sir.
So luckily he is well controlled with one tablet, 2 tablets of 5 milligram amlodipine per day.
Yes, sir.
Who are all the patients who will develop or require more number of antihypertensives?
Patients, especially patients who has got a secondary hypertension, sir. Patients of pheochromocytoma or a patient of any biopsy changes like an IgA nephropathy and nephrotic syndrome. Such patients requires higher. They usually tend to have a high BP, sir.
Okay, but what about CKD patients? Which type of CKD patients will require more than one drug?
Usually, patient in the class 4 and 5 end-stage disease, they will be recurring, sir.
Do all class 4 and 5 patients develop, or some other added pathology that develops in them causes the requirement of additional antihypertensives?
Oh, those who have got with the sodium retention and also.
Okay, any of them? You said sodium will be low. How can they be having sodium retention? Those who develop early atherosclerosis, the CKD patients have a tendency to develop atherosclerosis, or patients who have developed CKD secondary to renal artery stenosis. Okay, so those are the patients who will require more number of antihypertensives rather than a single antihypertensive. Okay, so what other drugs are preferred or given commonly apart from amlodipine? What other antihypertensives are preferably given, especially if they have diabetes mellitus also in the early stages of CKD?
ACE inhibitors can be given, sir, like enalapril and all. And angiotensin receptor blockers also, ARB blockers also can be given, sir.
Yes. So how to decide which drug, whether you can give ACE or ARB? Do you have any particular indication where it can be safely given?
So patient with usually any glomerular changes, like if they tend to have more of proteinuria and all, they can be given ARBs or ACE inhibitors, which tends to prevent the proteinuria, sir. Apart from
mild proteinuria, if they have established very severe proteinuria, you should not give. It will rapidly deteriorate that patient. Okay, patients who have in the very early stages of microalbuminuria, they can be given to prevent further deterioration of ACE and ARBs. But if they have more than 300 milligrams in 24 hours of protein excretion in the urine, you should better avoid that because it will rapidly deteriorate and make them worse. So it's a double-edged weapon. Early stages, it prevents progression of the CKD, whereas in the late stages, if it is established and it is given, then it worsens the condition much faster. Okay. So glycomet, what is the risk of this glycomet?
Glycomet is metformin, sir. So the patients usually with a high creatine, metformin should be avoided, sir, because the elimination will be altered.
What is the complication they can produce in long-term use? Anything to do with lactate?
Lactic acidosis they can have.
Lactic acidosis. So they can develop lactic acidosis. So it should be stopped well before surgery, even if they are taking it for a long time, because 12 years history you are giving. So that is the reason why all these questions should be asked and all the answers should have been elicited from the patient. Okay. And last drug, the jardinase.
That is dapagliflozin, SGLT inhibitor, sir.
SGLT inhibitor. What are the risks of SGLT inhibitors?
It's actually the duration of action is around 24 hours, sir. So ideally it should be stopped one day prior, because if it is not stopped, there is high chance that hypoglycemia can happen, sir, during surgery. Okay. And what type of ketoacidosis it can produce? or
Is there any special type of ketoacidosis caused by this SGLT2 inhibitors?
hyperosmolar?
It is called euglycemic
Euglycemic
ketoacidosis.
yes.
Patients will not have extremely high blood sugars, like what you normally see in the classical diabetic ketoacidosis. In which type of patients classical diabetic ketoacidosis or DKA will happen? Type 1 or type 2?
DK is usually type 1, sir.
Type 1 patients are more prone to that. Okay, but type 2 will not happen. But patients who are taking SGLT2 of late, it is being prescribed more commonly. They have the tendency to develop ketoacidosis with a normal sugar. So it is called euglycemic ketoacidosis. What other complication can be produced by this drug?
They can have patient with Jardians can have a chance of UTI also, so
recurrent UTI. Okay,
yes,
and especially a patient with a renal stone or a ureteric stone who is going to undergo endoscopic procedure like URS, the chances of post-op UTI and their complications are very high. They can go for urosepsis also. Okay,
yes.
That is a very, very grave post-operative complications. So you must ask all these things and establish and mention what are all the things that they are given for, because you have mentioned all the brand names. The examiners might ask you about whether you are aware of the composition and the generic name and their interactions with that has to be recorded in your history. Okay, right. Now you go to general examination.
On general physics examination, patient is conscious, oriented, well oriented to time, person, and place. He is moderately built and nourished. He is sitting comfortably on the bed while examination. His height is 177 centimeter, weight of 68 kgs, with a BMI of 21.7 kilogram per meter square. Temperature 98 Fahrenheit measured in left axilla, with a pulse rate of 82 per minute, which is regular, normal volume and character. There is no radial or radiofemoral delay. Blood pressure is 140 by 80 millimeter of mercury measured on right arm in supine position, and on standing position it is 134 by 76 millimeter of mercury. Respiratory rate is 16 per minute, abdominal thoracic, with a saturation of 98% room air. Pallor is present. There is no icterus, cyanosis, clubbing, lymphadenopathy, and edema. JVP is not raised. Airway examination. Mouth opening is 3 fingers adequate. Mallapetic class 1. Neck movements are normal. Spine normal.
Who is Mallambatti? Why do you say it is Mallambatti grading? What is the reason? Is it the procedure name or is it the name of the person who described this?
I don't, sorry sir, I don't know sir.
It's a history, we have to be very proud that it was described by an Indian anesthesiologist from Andhra Pradesh. His name is Seshagiri Rao Mallambatti. He migrated to Canada in way back in 1987, and he was working in the ENT unit. So he used to ask the patient to open the mouth and examine, and he was the one who introduced this classification of Mallambatti scoring to assess the probable difficult intubation. Okay?
Yes, sir.
Who modified that Mallambatti grading? Is there any modification, or this is the only grading that was done by?
Modification is there, sir. There is a class 0 also where the epiglottis is seen, sir.
That is grading. I am asking anybody modified his scoring system. What Mallambatti described, Seshagiri Rao Mallambatti described.
Yes, sir, there is a modified Mallambatti grading, sir.
That is not, see, he cannot modify his own grading. Somebody else has to modify.
I don't know.
Done by two people called Samsoon and Young. SAMSOON and YOUNG. Samsoon and Young modified the original Mallambatti grading. They introduced grade 0.
Yes.
What is grade 0?
Opening the mouth, epiglottis is seen, sir.
Even if the epiglottis is seen, it's grade 0. Yes. And grade 4?
Grade 4 is uvula is not seen, soft palate is also not seen, only hard palate will be seen.
Only sir. Hard palate is seen. Yes. Okay. What is the specificity and sensitivity of this testing? Is it 100% true all the time?
No, sir.
It is not. Okay. So it is about 80 to 85% specific, 88% sensitive. Okay. It is not 100% true. Okay. Suddenly they may ask you like this. Okay. You must be prepared to answer them. This will divert your attention on your regular presentation, and you should be able to come back and rejoin the presentation. Okay, that is very, very important, right?
Okay.
Then neck movements.
For this patient is normal, sir. And spine is normal, and the teeth is also normal, so there are no dentures or missing teeth.
Okay, very good.
Breath holding time.
Supposing patient has got a shaky tooth in the upper incisor level.
Yes, sir.
What will you do?
If it is a denture, sir, we will ask the patient. If it is a
No,
removable,
I'm saying shaky tooth. It's not a denture. It is a normal tooth which is shaking because he is already 57 years old.
Yes.
And he is a CKD patient. There's a chance that the calcium level may be normal and the bones are becoming brittle and tooth is shaky.
Yes.
So if it is said, if it is the upper incisor which is shaky, what will you do? What will you advise the patient?
One thing I'll advise the patient, there is chance that that tooth can be broke
dislodged.
dislodged.
Okay.
And while intubating, I'll put a tooth cap, sir.
Okay. Or you can ask the patient to get it removed, attend a dental clinic and get it removed so that it doesn't get knocked off while you are going to do the laryngoscopy. Okay? Otherwise, you will be in trouble. This has to be documented. Whenever a patient has got any shaky tooth in the oral cavity, it is better you document it and inform the patient and relatives and get it signed by them so that you are not blamed for the loss of the tooth, and explain them that it may be knocked out during the anesthesia. Okay?
Yes.
Right. Okay. Go ahead.
Breath holding time is 30 seconds. Meds of 0.7, more than 7. And
what is meds?
Meds goes for metabolic equivalent of task score, sir, where we compare the exercise tolerance capacity and the oxygen intake of a male patient who is 40 years old with a weight of 60 kgs.
Very good. How much is should be? What is the normal value?
It's a 1.34 ml per minute.
So low? I think it's about 3 to 3.5 ml per kg. Okay, right. So ultimately, your ASA scoring, grading, you have come to ASA grading.
Yes, belongs to ASA 2, sir.
Okay. Why do you say it is ASA 2?
ASA 2 consists of a patient who has got any comorbidities which is under control, sir. So my patient regarding the hypertension and diabetes which are under control, and the CKD parameter also, like his urine output is even the creatinine is normal. Urine output is normal, sir.
Okay.
And he is not
how many grades are there in the American Society of Anesthesiology scoring?
ASA 1, 2, 3, 4, 5, sir.
Only 5?
And with the ASA emergency also, sir.
You should not forget. Always you may start the emergency also as one of the classes. Okay. Well, what is the purpose of this ASA grading?
We can predict the morbidity and
morbidity and mortality. Okay. So if a patient is ASA 1, what is the mortality?
It's around 5 to 10%. I'm not
5 to 10% for ASA 1? That's too high. It's less than 1%.
Okay.
If a patient belongs to ASA 1 category, because all these things I am asking, because if something goes wrong in the court of law, these are all the points which will be asked. You have given them ASA 1 grade, and how did this morbidity happen? Then you have to give the statistics. Normally it is less than 1%. That is what is being given in all the statistical values. Okay. So you have to keep it in mind. Right. Go ahead.
Coming to systemic examination, per abdomen inspection, the shape of the abdomen is scaphoid. Umbilicus is in central. Movement of abdomen with respiration is noted. There is no visible pulsation or peristalsis or sinus or scars. Skin of the abdomen appears normal.
Okay.
On palpation, abdomen is soft, non-tender. There is no palpable organomegaly. There is no local rise of temperature. On percussion, tympanic notes heard on all quadrants of the abdomen. On auscultation, bubble sounds heard. Genitalia appears normal.
Very good.
Coming to respiratory system, bilateral normal vesicular was heard. No abnormality detected. And CVS S1, S2 heard, no murmur. And CNS higher mental functions normal. Sensory and motor system normal, and reflexes are normals.
Okay. That completes your examination of the patient also. So what you have described as abdominal examination, be prepared to practice it and then recall it,
Okay, sir.
because there is one station where you have to demonstrate some examination of the patient in the practical examination. So
Okay.
if your patient is a CKD patient and you want to examine the abdomen, you have to go systematically looking at all the 9 quadrants, and then you must mention about fluid thrill, presence of extra fluid, and all those things also. Okay, so you must know how to do. So before exam, please read about the your surgical handbook, how to do the abdominal examination and present it in the correct way.
Sure.
So finally, now with all this history and complaints of the patient and history taking, what is your final diagnosis?
Summarize. A 57-year-old male patient with non-case of diabetes, hypertension, CKD on medications, with elevation of serum creatinine, and then having a normal urine output, with previous history of URS surgery, presented with a right-sided abdominal pain and hematuria. On examination, pallor is present with a normal physical and systemic examination. Patient is planned for right URS with a DJ stenting, sir.
So here, do you have any suspicion that this patient may be having CKD clinically?
There's one pallor.
Pallor is the only thing. There is no
Yes,
swelling in the face, no swelling in the limbs, no edema. Okay.
Yes, sir.
What is the other confirmatory evidence that he has been he is a CKD patient? Apart from your clinical examination findings, what is the other confirmatory evidence that he is a known CKD patient?
One thing is the blood pressure, sir. It is in the up 140/80, sir. Considering his age and
140/80 is not. It is an accepted high normal. 140 is accepted high normal in systolic.
Yes.
Uh,
And he is on medication, sir, which is usually given for CKD
Not
patient.
only medication. 3 years ago, he has been confirmed as a CKD patient when he came for the surgery. Okay,
Yes, sir.
that is the very confirmatory evidence. Probably they have done all the investigations and then only branded him as a CKD patient. Okay,
Yes.
So how come this patient is not exhibiting? What are all the classical features of a CKD patient? Will they all be non-edematous, non-hypertensive like your patients?
No, sir. Patient can have edema, sir.
Okay.
And clinically,
what type of edema they will have in this to start with? When they develop the CKD, is it a chronic disease or a acute disease?
It is usually start with an acute, sir. And usually
Starts acutely all the time.
No, sir.
You say it is a chronic kidney disease. So chronic means it's a long duration.
Yes, yes.
So how do you exactly define CKD?
It is defined as a functional and structural impairment of the kidney, sir. With
Functional or structural. It is
yes,
not
sir.
combined with both. Okay? It is a functional derangement of what function is getting deranged?
The renal function is deranged. So the creatinine clearance and urine output is
See, more than creatinine clearance and all that, what exactly you must know the definition of chronic kidney disease.
Yes.
Chronic kidney disease is a progressive, irreversible deterioration in the kidney function in the form of reduction in glomerular filtration rate.
Yes. With
that is the definition. More than 3 months duration.
Yes.
So it is a progressive one. It is a irreversible one. It doesn't come back. Whereas acute kidney injury, can it come back to normalcy?
Yes, sir.
That is a major difference between the chronic kidney disease and acute kidney injury. Okay, acute kidney injury, after a period of rest and the treatment with renal replacement therapy, the kidneys can revert back to their normal function. Whereas in CKD, it is a progressive, irreversible damage.
Yes,
right?
Yes,
so that is in that case, what will be the presenting feature of that edema? Will it happen in the legs, hands, or face?
In the legs, sir, usually pitting type edema, sir, bilateral.
Usually, renal puffiness of face is the common ailment or the complaint the patient will have. Okay, CKD patients in the early stages usually develop puffiness and the swelling of the eyelids in the morning, and then it disappears as the day progresses. That is the classical description that they will give you. Okay, so that is what you have to ask for and establish. So gradually it will be reduction in urine output also. Your patient is luckily having a normal urine output. How is it possible? How can a patient with a decreased kidney function, chronically affected kidney, how can it excrete normal urine output?
Right now, he's on a couple of medications, sir, which is makes his condition under control, sir. And one thing is the cause of CKD was initially the stones in the left ureter, sir, which has been removed surgically. So after that, there is no further impairment of the any insult was not there, sir, for the kidney.
Okay. What is the physiology of normal urine formation? Can you describe briefly how urine formation takes place in the normal healthy kidneys?
Basically, the kidney consists of the cortex and medulla, sir.
Very good.
It consists of the medullary part and the cortex part, which and proximal convoluted tubule. There is a descending loop of Henle, then the distal convoluted tubule, ascending loop of Henle, and the collecting duct, sir. So, and there is a countercurrent mechanism also, which helps in the maintaining the electrolyte imbalance, sir. Okay. And when the urine is like passed through the proximal convoluted tubule, with then it tried to filtrate all the toxic components, which includes the creatine and other parts. And there is subsequent reabsorption of water and the glucose and the electrolytes happens with a couple of sodium, potassium, ATPase receptors, and the sodium chloride transporters.
Okay.
The SGLT transporters also.
If this question is asked in your examination, can you describe the physiology of urine formation briefly?
Yes, sir.
You can answer like this. The functional unit of the kidney is a nephron.
Yes.
Okay. And it has got three basic things. One is called the filtration, the glomerular filtration. Then there is a reabsorption. Then there is a third process called secretion.
Secretions, yes.
These are the three things that help to form the urine. So how much of filtration occurs? How much of plasma is filtered in a day?
Sorry, sir.
Almost 180 liters.
Okay.
In 24 hours, 180 liters of plasma is filtered by the glomerulus. Okay. But what is your total urine output per day?
It's 1.5 to 2 liters per day, sir.
1.5 to 2 liters maximum. So out of 180, almost less than 1% is only passed out as urine. So the rest of all is all reabsorbed at various levels. In addition to this reabsorption, there are secretions into that, like secreting the potassium, secreting the urea, secreting creatinine. So some secretions occur. So you simply describe only these three steps: filtration, reabsorption, secretion at various levels. And you must know these two important values. 180 liters of plasma is filtered per day, ultimately concentrating it to have excretion of 1 to 1.5 or 2 liters of urine. Okay. So all the rest of the process, what you described, that's all happening at various levels. Right from the proximal, 80% of what is filtered out is reabsorbed at proximal convoluted tubule itself. Then the loop of Henle mainly plays a role in making the urine concentrated. And what is the pH of the normal urine?
It's 7.3 to 7.4.
7.3 means, is it almost like blood? Normal urine is acidic in nature. It's 4 to 5 pH. Okay. So when it is more concentrated, a person is dehydrated, will the pH go down or increase?
Goes down, sir.
Goes down. It becomes more acid. That is why you get a burning. When your urine is concentrated, when you are dehydrated, you have a more burning sensation while passing urine because it becomes more acidic. Okay. So sometimes all the questions about the normal urine physiology will be asked. So the specific gravity or osmolality, the pH, the contents. What are all the normal contents in the urine, in a healthy person's urine?
Usually, like there will be minute of RBCs will be there, sir. Epithelial cells.
There should be no albumin or protein.
No,
that is very, very important. In a healthy kidney person, urine should not have any protein. There may be stray RBCs, there may be stray bacteria. Can you have a cast? You should not normally have a cast also. What is a cast?
Yes, sir.
What is a cast in the urine? What are all the various types of cast you can get?
Epithelial and the WBCs.
You can have a RBC cast, you can have hyaline cast, you can have bacterial cast. Okay, so what is exactly a cast? How is it formed? It's formed by the coagulation of a protein. That's called the Hartswall's protein is there. HORS FALL. Hartswall protein is there in everybody's kidney. Because the urine flow is very fast, this protein goes out in a normal way, but it is not included as the albumin or other protein. Okay, whereas in a slow flowing urine, when the urine quantity is decreased, this Hartswall protein gets coagulated and forms a cast. And that cast can include either an RBC or a hyaline membrane or a WBC or a bacteria, and that can be seen only under the microscope. And RBC casts are pathognomonic for acute kidney injury. So if you examine the urine and there are RBC casts present, that condition will be a AKA, not a CKD. Okay, that is a very important distinguishing point which can be easily made out. So any person with a less than 3 months duration of kidney problem, you have to do a routine microscopic examination to find out the presence of RBC cast in the urine. Okay, so that is a very valid point that you have to remember.
Yes.
Right. So your patient is having, so he has a tube. Now, how was this patient anesthetized for the previous surgery done 3 years ago?
It was under general anesthesia, sir.
General anesthesia.
Yes.
With a endotracheal intubation or without endotracheal intubation?
With endotracheal intubation, sir.
Intubation. Okay. So why I am asking, can it be done without endotracheal intubation?
It can be done, sir. This time we can put a laryngeal mask airway also.
Very good.
The previous history of general anesthesia, one thing we can make out the easiness of intubation, whether there was any difficult intubation or anything was there or not. That history we can elicit from the patient, sir.
Very
and any complications.
What are the advantages of using a supraglottic airway compared to endotracheal intubation?
In supraglottic airway, the airway stays above the glottis. It does not pass through the vocal cords. And chance of bronchospasm and all is less compared to endotracheal tubes.
Okay. What is the most important difference between endotracheal tube intubation using a laryngoscope and insertion of a LMA without any use of laryngoscope? What is the most important difference?
Patient tolerates the airway better than endotracheal tubes, and we can maintain conscious sedation also.
When you do a laryngoscopy in intubation, what happens to the patient's cardiovascular system response?
Stress response increases. There is a hyping blood pressure and heart rate can happen.
So there is a sympathetic stimulation. Okay, that is totally avoided. So is it preferable to use an LMA for this because your patient is already hypertensive? Is it advisable to go for an LMA rather than an endotracheal intubation?
Yes, sir. Yes, sir.
Very good. So if all the patients more or less develop this sympathetic response or stimulation to laryngoscopy and intubation, what are all the methods to avoid or control that? How do you abolish that sympathetic response?
Prior to intubation, sir, we can give Silocards, so that is lignocaine, preservative free. We can give a dose of 1.5 mg per kg, sir. And we can give a beta blockers, short-acting beta blockers like esmolol, we can give, sir, 0.5 mg per kg.
Very good.
And other drugs like pre-medications like midazolam and fentanyl also can be given, sir.
Okay. Any other newer drug used in opioid-free anesthesia, which also can be of help? Magnesium sulfate. Okay, magnesium sulfate is also another drug which can abolish the sympathetic response. Where else do you use magnesium sulfate intraoperatively?
Magnesium has got a wide variety of use, sir. It can be used in case of pregnancy-induced hypertension.
No, I am asking mainly to control the surge in blood pressure, sympathetic stimulation.
Yes.
Which other surgery you can use magnesium sulfate intraoperatively? Not during laryngoscopy and intubation.
As a painkiller medication, we can use it, sir. And
That is a part of opioid-free analgesia regime. But I'm asking you to control the blood pressure. Which are the other conditions where you can use magnesium sulfate?
During intubation, we can use, sir.
No. I'm specifically saying not during intubation. I'm asking intraoperatively. After you have intubated and you are proceeding with the surgery, intraoperatively, which surgeries can cause a surge in BP, which can be disastrous, and that can be blocked or prevented by magnesium sulfate.
Spine surgery, sir.
Pheochromocytoma?
Yes.
You can do that. Eclampsia, preeclampsia. Yes. Okay, these are common conditions. Spine surgeries, of course, we do use it, but not as a routine. But pheochromocytoma, it is part of the regime to control the blood pressure surge. Very good. Right. So these are the questions that will be asked with regard to laryngoscopy and intubation and use of LMA. But what is the risk of using LMA for a URS procedure?
Aspiration can happen, sir.
Why?
Because in URS procedure, the patient is in lithotomy position, sir. So
very good.
Intra-abdominal pressure can increase, sir, and that can go beyond the barrier pressure. And
very good. What is barrier pressure?
It's usually intra-abdominal pressure, sir, which is usually around 10 to 15 centimeters of water more than the lower.
No, intragastric pressure. It is not intra-abdominal pressure. It is the lower esophageal sphincter pressure, which should be 10 to 15 centimeters more than the intragastric pressure. That is what is called the barrier pressure, which prevents the regurgitation of gastric contents into the esophagus. Okay, very good. So to manage this risk of aspiration, what type of LMA would you like to use?
We can use a second generation LMS with a rails tube port for rails tube insertion. Such LMS we can use, like a Supreme LMA, iGel.
What do you call that port for aspiration? It is called gastric port.
Gastric port,
it is not a port for using LMA. Of course, we can insert LMA, the rails tube, but it is called the gastric port to remove that. What is Buska mask?
Buska mask is also a type of LMS, sir.
What are the advantages of Buska mask?
It doesn't have a cuff, sir. And even that also protects from aspiration, sir.
How many tubes are there in the Buska mask for aspiration?
It has got a gastric port, sir.
It has got another air port.
Airport, yes.
Why that airport is there? The tube for air insertion in or entry into the gastric content. Otherwise, when you apply suction, the gastric mucosa can collapse. So to prevent that only, you have another port through which constantly air will go and keep the stomach open so that you can easily aspirate. It is to prevent the collapse of the abdominal gastric walls, to prevent the sucking out of the contents. So these are all some small tidbit like questions which can be asked. So he has undergone the previous surgery under general anesthesia without any problem and complication, but they have established the diagnosis of CKD at the time itself.
Yes, sir.
So what was the urea creatinine level at the time, and what is the urea creatinine level now? Have you done the investigations for him?
The last investigation was it was done 2 months back. Creatinine was 2.3, sir.
2.3. Okay.
Yes.
So any estimation of GFR done?
Yes, sir. GFR estimation is done, sir. So according to Cockcroft formula, it comes to be 32 ml per minute per 1.73 meters square, sir.
So what type of GRF, if you use Cockcroft and Graph formula, what is the name for the GRF?
It's measured, sir.
It's estimated. It is not measured. It's an estimated GRF. Right? The measured GRF should be, how do you do measurement, actual exact measurement of GRF?
We measure the urine creatinine ratio, sir, and the plasma creatinine and the urine flow rate. And the equation is the urine creatinine ratio multiplied by the urine flow rate divided by the plasma creatinine ratio, sir.
Creatinine clearance or inulin clearance. Okay, these are all substances which are not reabsorbed. So that clearance has to be estimated. So you first take a blood sample, assess the creatinine level, then collect the volume of urine for 24 hours. Then you establish or assess the creatinine in the volume of urine and then see how much is excreted, and that is what is called the creatinine clearance, which was the method done 20 years ago.
Okay.
Later on, after knowing that they can calculate it using this formula, they have now accepted eGFR, that is estimated GFR, as a acceptable or a reliable method of estimating the GFR also. Okay, right. So now this patient is come for the second procedure of stone removal. How are you going to anesthetize him now?
So first of all, while doing a preoperative examination, after taking a thorough history of the patient, I will do the necessary investigations, sir.
Okay.
So which includes starting from a complete blood count to mainly look after the hemoglobin level, and to see the total counts also, to see any infections are there or not.
This hemoglobin, is it low or normal?
No, low, sir.
Low. Why these people have a low hemoglobin? People who are diagnosed to have CKD, why they have a low hemoglobin?
One reason would be the erythropoietin level is less, which the stimulation for production.
What is erythropoietin?
It's basically a hormone which helps in the production of RBCs, which is usually produced
biochemically by what is it?
Don't know.
It's a glycoprotein.
Okay.
It's a glycoprotein, glycolipoprotein. Where is it formed in the kidney? Which part of the kidney?
The juxtaglomerular apparatus, sir.
Glomerular?
Juxtaglomerular apparatus, sir.
It is the mesangial cells of okay. So what is the trigger or stimulus for the secretion of erythropoietin?
Hypoxia is.
Hypoxia. So when the patient has got low, then only the erythropoietin will start working, and in patients with kidney disease, it is not there. But lack of erythropoietin, is it the primary reason for developing anemia?
Also, they can have the uremia-induced bone marrow suppression can happen, sir.
That is the first primary change that happens. Chronic accumulation of urea causes the suppression of bone marrow productions, and that is the first reason for reduced formation of RBCs.
Yes.
Then normally when you have a low RBC count, the oxygen carrying capacity decreases. That will stimulate erythropoietin production to increase the number of RBCs.
Yes.
So because the kidneys are already damaged, erythropoietin is not adequately secreted. So compensation or corrective procedure cannot take place in these patients, and they remain to continue to be anemic. Any other reason for the anemia apart from bone marrow suppression?
And usually CKD patients, they can have malnutrition, so that, that nutritional supplementation can come down. That can also be a factor for anemia, sir.
They develop normally nausea and vomiting.
Nausea, yes.
Why do they develop nausea and vomiting?
The one of the reason could be uremia itself, sir. That
uremic gastritis.
Yes. Secondly, you can have a hyponatremia that also can have a manifest as nausea and vomiting, sir.
Oh, very good. And what are the adaptations the patient undergoes? Because this anemia is not an acute anemia, it is a chronic anemia, occurring gradually over a period of time. So what are the adaptations the patient develops to maintain?
The oxyhemoglobin dissociation curves that tends to be into falling towards the right side, sir, right? And there will be increase in 2-3 DPG level can happen, sir. And so the delivery of the oxygen to the tissues will be increased.
Very good. Okay. Right. So the blood, you mainly want to see the hemoglobin level. So yes. what level of hemoglobin you will accept this patient for surgery?
In chronic kidney disease patient, up to hemoglobin level of 9 is fine, sir.
So you need the same 9 for this procedure of URS?
No, sir, because the blood loss is very minimal, sir, in URS.
Very minimal.
Yes.
So how do you know that he is fit enough to undergo surgery and anesthesia now? What questions you will ask the patient with regard to his anemia?
So clinically, I'll ask the patient, sir, like whether he is having any symptoms of tiredness, any palpitations, and giddiness, and it's
functional capacity, whether he is able to climb a flight of stairs. The METs what you described about is very, very important.
Yes.
So without any breathlessness or giddiness, tiredness, if he is able to carry out his day-to-day work, that means he is a well-compensated patient. And because this surgery is not going to cost very much, you don't expect any heavy bleeding in this surgery. You can accept even if the hemoglobin is 7 or 6 grams. What is transfusion trigger?
Transfusion triggers are usually for a patient who is undergoing surgery, where there is, if we anticipate a huge blood loss, then we usually consider the baseline hemoglobin and the hemoglobin which is expected for the patient. So usually for a patient who is going for a high-risk surgery, the the least hemoglobin level accepted can be up to 9. So, and if a patient who has got any cardiac issues, the hemoglobin, the least hemoglobin which is accepted around 10, sir. And
So
we'll
the
calculate
trigger means the need for transfusion.
Yes.
That question there. So the wording transfusion trigger means what is going to trigger the need for a transfusion. That is determined by the nature of surgery and the blood loss that is going to be involved, and the patient's adapted condition, whether he is compensated for the anemia or not. These two have to be taken into consideration. For example, a patient with 7 grams hemoglobin is able to swim a lap of 100 meters or 200 meters without any difficulty, and he is going to undergo a hernia surgery. He can be easily taken up. You don't have to correct his hemoglobin to 9 grams and take him for surgery. Whereas on the contrary, if it is going to be a vascular procedure, a suprainguinal vascular anastomosis, then you have to correct his anemia before surgery and then only take him up. Okay, that is what is called the transfusion trigger, which is dependent on two factors. One is patient's compensation. Second is the nature of surgery and how much of blood loss is expected. Okay, these are the two factors which should decide whether you have to give a preoperative transfusion to correct the anemia or not. Okay, right.
Okay.
What about his platelets? In the complete blood count, nowadays you get platelet also. Will the platelet be decreased in number?
Usually the platelet, the number will be same. So the functional property of the platelets will be hampered, sir. There will be a platelet dysfunction can happen. So patient can bleed also, sir.
So what is that condition called?
It's a thrombasthenia.
Thrombasthenia. Very good. Is there any drug to correct this thrombasthenia?
Desmopressin we can give, sir.
What is the dose?
It's 0.3 mg per kg.
That is subcutaneous.
Yes,
given by subcutaneous route, not by intramuscular or intravenous. Okay. So that will try to correct the thrombasthenia or platelet dysfunction. Okay. What other investigations you want in this patient?
So apart from that, then I'll do the blood sugar level of the patient, sir, and the HbA1c level also to see the 3 months control of the sugar levels. Then I'll do the coagulation profile, so PTINR, and also I'll do the complete renal parameter test, which includes a blood urea nitrogen, serum creatinine, and serum electrolytes also I'll get it done, so to see the baseline, the sodium level, the potassium level, even the calcium level also. So.
Okay. What happens to the various electrolytes? What will happen to sodium? What will happen to potassium? What will happen to calcium? What will happen to magnesium, phosphate?
So sodium usually they can have a hyponatremia, so or it can be a normal sodium level also. And potassium CKD patient tends to have a higher potassium level, usually hyperkalemia. So.
Very good.
They can tend to have a hypocalcemia.
Very
the one thing reason could be the vitamin D level is less and the intestinal absorption of calcium is less. Secondly, they can have a secondary hyperparathyroidism also.
Okay.
And so these all relative.
About magnesium and phosphate, is it important also? Very important.
Yes, sir. The phosphate level can be high, sir. And magnesium level also can be less, sir.
Can be low. Okay.
Yes, yes.
What is the important? Supposing the patient's what is the normal magnesium level?
Magnesium, the therapeutic level is 2.5 to 4, sir.
4 milligram. So if supposing this patient has a low magnesium before surgery, what is important? Does it have any bearing in your anesthesia?
Yes, sir. Like the potassium level also can be altered because there is an altering.
With regard to magnesium, if supposing he has a low magnesium, hypomagnesemia, does it have any straight involvement or importance in your conduct of anesthesia? Which drugs will be potentiated?
The neuromuscular agents will be
That is an important thing. Okay,
yes.
so you have to remember that. So even after the completion of surgery, if your patient is not attempting, it is still paralyzed, it may not be the drug which is the fault, it may be the neuromuscular junction which is not responding because of hypomagnesemia. Okay, so that is a very important pre-op investigations. So majority of the people look only at potassium level because we are worried about hyperkalemia more than hypomagnesemia. So
Yes.
why you are worried about hyperkalemia?
Hyperkalemia can cause arrhythmia, sir. And
What
it
arrhythmia?
causes usually more commonly ventricular fibrillation, sir.
Hmm.
And the patient can have a cardiac arrest also.
Okay. So how do you correct this hyperkalemia?
It's usually corrected with the calcium gluconate, so 10% calcium gluconate administered over 20 minutes slowly. Secondly, we can give insulin GA drip we can give, sir. So then third, we can give a inhalation of salbutamol, beta agonist.
Supposing patient is having hyperkalemia in the pre-operative time itself, will you go for the routine administration of calcium and glucose insulin, or will you?
We can give K-bine sachets, sir.
So the treatment depends on the stability of the patient and the time of the occurrence. Okay, hyperkalemia, which is life-threatening, has to be controlled with calcium gluconate. It's an emergency treatment. Similarly, glucose insulin infusion also is an emergency correction. Whereas if the preoperative patient has got a chronic hyperkalemia, you can control it either by the binders or you can go for hemodialysis. Okay, it is not necessary that it should always be treated only with calcium gluconate. So in life-threatening or an intraoperative situations, you go for either calcium gluconate IV or potassium, so insulin and glucose infusion, GIK. Okay. So that is what you have to do, remember. Right. And okay, go ahead. So this patient, you want to do these investigations? Any ABG you want to do?
Yes, sir. So, yes, sir. RT blood gas analysis I'll do, sir. And just to determine what is the pH of the patient, current pH, as well as the PCO2 levels, PO2 levels, and the bicarb levels, sir.
Very good.
And
so, if the patient has got a normal pH but low bicarb, what does it indicate?
It's a compensatory
metabolic
acidosis.
Very good. Okay, right. So all these investigations have been done, and you find the patient is fit. What are your preoperative orders?
So in preoperative orders, I'll first counsel the patient, sir. I'll tell him what type of anesthesia I'm going to administer the patient. Then I'll take a consent also, and regarding the procedures, and even high risk consent I'll take because he's a CKD patient, sir. And then I'll advise him about what all the medication he has to take on just prior to the surgery. So for in this case, I'll continue all the CKD medications. Then I'll avoid oral hypoglycemic agents. And I'll ask him
to avoid both glycomet and SGLT2 inhibitors.
Yes, sir. Yes, sir.
You will avoid both. Okay.
Yes.
Then how will you control the sugar? Supposing he is used to this drug, one drug in the morning, glucomet, and night he is taking SGLT2.
Yes. We'll do
on the day of surgery, his blood sugar is 180 fasting. Yes. Will you take up this patient or will you avoid this patient?
We'll take up, sir. We can give insulin according to sliding scale with strict monitoring of the glucose levels following insulin. And so I'll ask him to continue his antihypertensive medicines.
Okay.
Then I'll give him aspiration prophylaxis like injection metoclopramide 0.15 mg per kg and injection pantoprazole 40 mg 40 mg. And then on the day of the surgery in the operation theater, I'll confirm my anesthesia workstation, the suction apparatus, the airways, and emergency trachea. I'll be keeping it ready. And after checking the consent and recounseling the patient to his satisfaction, I'll be taking him to a operation theater with ambient room temperature. And after that, I'll be connecting all the monitors according to the ASA standard protocols like ECG, the SpO2 blood pressure monitoring. And I'll be taking IV on the site where the local anesthetic patch is applied. and I'll start the IV fluids. And it should be a restricted IV fluid because it's a CKD patient. And my plan for anesthesia is a general anesthesia, so I'll keep all the drugs ready, and all the airway equipments will be keep it ready. And then I'll pre-medicate the patient with the injection glycopyrrolate, 0.2 mg, injection fentanyl 2 mics per kg, then injection ondansetron 0.1 mg per kg, and the injection I'll pre-oxygenate the patient. So I'll pre-oxygenate of almost for 5 to 6 minutes. Then I'll induce the patient with a propofol 2 mg per kg. Then after induction, I'll do a check ventilation whether I can ventilate the patient or not. After check ventilation, I'll administer it, and since it's a myelopathy class grade 1, I'll administer atracurium 0.5 mg per kg. And after that, waiting for 3 minutes and action of muscle relaxant has come, we'll intubate the patient, and they'll check the bilateral air entry with the oscillatory methods as well as with confirmatory with the ETCO2. Then I'll maintain the patient with nitrous oxygen and desflurane. And the pain management part, I'll give paracetamol 15 mg per kg, and the restricted fluid therapy will be given, and the anesthesia will be maintained, and we'll be extubating the patient following the surgery after all the extubated parameters are confirmed. And I'll use neuromuscular monitoring also, because there are patients can have a potentiation of neuromuscular action can happen. Also, the temperature monitoring, ETCO2 monitoring will be done, so, and the urine output also.
Sir, supposing the urine output drops, intraoperatively there is a drop in blood pressure after you are induced and position the patient while the surgery is going on, there is a drop in blood pressure and the urine output is not there for 2 hours. What will you do?
So one thing could be a hypovolemic issue, sir, since the blood pressure also came down. So first I'll try with the pushing of around 100 to 200 ml of fluid, sir. And we'll see whether the urine output has improved or not. And to maintain the BPA, I'll use vasopressors. So it can be either ephedrine or phenylephrine. If it's not controlled with any of these tests, I'll start on noradrenaline, sir.
Okay.
And then I'll
assess. Diuretic will be of use?
Yes, sir. Yes, sir. I'll use furosemide, sir.
Furosemide.
Yes.
22. What is the dose you can try?
Like 10 to 20 mg initial dose, bolus dose I'll give, sir. Then subsequently we'll monitor the urine output and give accordingly, sir.
Yes, sir. So what is the main goal in anesthetizing a patient who is a known CKD patient coming for a non-renal transplant procedure? What is your main goal in the
basically, we have to monitoring we should avoid hypovolemia. We should avoid hypoperfusion and hypoxia, sir.
Yeah, and maintain whatever renal function is already there. The GFR that has been calculated should be maintained so that he doesn't develop what is called acute kidney shutdown or injury in the chronic kidney disease status. Okay, that is our main goal in managing these patients. Okay,
right. And normothermia will be maintained.
Normothermia, very good. So in this patient, supposing he over a period of time gone in for severe CKD and requires a renal replacement therapy. What are all the indications for starting a renal replacement therapy?
So the renal replacement therapy, the indications are like based on criteria, sir. So usually the one criteria is the urine volume, sir. If the patient is having a oliguria, that is almost a passing of 200 ml of urine in 12 hours, or if the patient is having an anuria, that is passing out either nil urine or up to 550 ml of urine in 6 hours, or if he has got any increase in the urea level more than 98 milligram per deciliter, or an increase in the creatinine level of more than 4.5, or patient have a hyperkalemia of more than 6.5, which is not getting controlled with the medications, or if he is having a sodium level of less than 110 or more than 160, and or in case of other cases of starting RRT is a pulmonary edema which is not responding to any diuretics, or presence of any poisoning or toxins can be removed through the dialysis.
What about acidosis?
As refractory acidosis also we can.
Refractory severe acidosis is a very, very important indication to start on dialysis.
Yes.
So what are the methods of starting dialysis? What is acute dialysis? What is elective dialysis?
So we have like intermittent dialysis and continuous dialysis, sir.
That is about the duration or the timing interval. But the onset of dialysis, how can it be done? Supposing it is an emergency dialysis, how will you do? How, if it is an elective dialysis, how is it performed?
So in emergency dialysis, we'll put an HD catheter, hemodialysis catheter, and it starts. And if it is elective dialysis, we can put a AV fistula, and we can start.
Okay. What type of anesthesia is required for AV fistula?
AV fistula we can be do under either local anesthesia or a regional brachial plexus block also. And if the patient is not comfortable with any of these, or if not is irritable.
Which are all the arteries and veins connected in AV fistula?
The radial artery and the cephalic vein is one connection, sir. And
at what level?
In the wrist levels.
Wrist level, or supposing that is not feasible,
then the brachial artery and basilic vein at the cubital levels.
At the cubital fossa, or it can go for, so this is a natural anastomosis between the artery and vein.
Yes.
Supposing the vein is very flimsy, what do the surgeons do?
With the local anesthesia, we can give, sir, so the vein can be vasodilated.
No. What do the surgeon? What is the surgical alternative for natural anastomosis between the cephalic vein and the radial artery, or the brachial artery and the cephalic vein? Supposing the vessel is very small, sometimes you get patients whose vessels are not of normal size to make an anastomosis and communication between them. So what do they do in such situations? They use an artificial graft. Okay. They put a artificial Gore-Tex graft between the artery and vein and establish a communication. Okay. So that may require a little bit more of extensive anesthesia, which can be provided by a brachial block in the form of axillary block, or in the supraclavicular block can be given to proceed with that particular surgery.
Okay.
What is dialysis disequilibrium syndrome?
There's dialysis disequilibrium syndrome usually happens after dialysis. So basically, the urea level in the urea can cross the blood-brain barrier, sir. And so after dialysis, the concentration gradient can be different, and it can cause a transient cerebral edema, sir.
So what will be the patient's complaints in that? How do you identify the presence of DSS?
They can have like altered levels of consciousness, sir. They can have seizures also.
Headache, nausea, vomiting, seizures, and unconsciousness. Okay, these are all the things that may happen in this. So one reason is the urea mismatch or urea transfer. Or any other reason for this dialysis disequilibrium syndrome?
I don't know the reason, so sorry.
The other reason is intracellular acidosis.
Okay.
Intracellular acidosis is the second reason for this. So you have to be very careful during the initial stages. Supposing some patients are not able to tolerate hemodialysis, what is their alternative renal replacement therapy? Every time you start a hemodialysis, immediately BP drops, patient becomes agitated, he becomes restless or throws a fit, and immediately you transfuse 1 liter of normal saline to restore the blood pressure, need some vasoactive drugs. So this happens every dialysis, hemodialysis attempt for 3-4 times. Then the nephrologist will say he is not tolerating the hemodialysis. Then what is the next alternative for these patients?
You can do a continuous renal replacement therapy, sir. For hemodynamic unstable patients compared to a normal intermittent time, sir.
One second.
Yes.
Okay. So this is the alternative is peritoneal dialysis.
Peritoneal dialysis also can. Yes.
So peritoneal dialysis, what is the mechanism? How does it help?
So in peritoneal dialysis, they will pass a catheter, sir, and which will be the one part of the catheter will be in the intraperitoneal space, and the portion of the catheter will be in the subacute and up above the skin level, sir. So they initially it consists of almost 4 to 6 hours dialysis and can be done at home also. The patient himself can do it, and they usually pass the dialysis fluid, and which will pass across the membrane, and which will absorb all the.
Which membrane is there in the peritoneal dialysis?
Peritoneal.
Which is the peritoneal covering is the dialysis membrane.
Yes.
Between the blood compartment and the dialysate compartment. What is the complication of the dialysate fluid?
Composition of dialysate fluid consists of sodium, sir. So sodium, like for a continuous replacement therapy, it is almost 140 millimoles per liter. Then consists of potassium, then around 3 to 5 millimoles per liter. Then calcium, then magnesium. And they usually consist of coagulant, anticoagulants. It can be sodium citrate or it
Your
can be
patient is already a known diabetic patient. In
Yes.
that patient, the peritoneal dialysis, can it cause any complication with regard to diabetes?
Yes, subacute peritoneal
No, that
peritonitis.
infection is common for everybody.
Yes.
With regard to the glycemic correction or glycemic state, can peritoneal dialysis cause any alteration? The dialysate fluid, is it hypertonic or isotonic or hypotonic?
It's hypertonic, sir.
It's hypertonic, made by what composition in that makes it hypertonic?
The sodium is there, sir. Sodium and chloride also.
Glucose.
Yes.
Okay.
Yes.
So patients will develop severe hyperglycemia. Okay. So already a known diabetic patient, if he is on regular hemodialysis, his blood sugars will be likely to go up because the dialysate fluid contains a lot of glucose, and that will migrate into the vascular compartment and raise the patient's blood sugar level. So how to control that rise in blood sugar level?
We can monitor the sugar level, sir. And
we can monitor the sugar, and then what treatment has to be given?
We can give insulin.
Yeah, you have to start them on insulin. Patients, yes, especially who are on only oral hypoglycemic agents, may require insulin.
Yes.
Normally, what will be the response once the known long-standing diabetic patients, if they develop CKD, what will be their drug requirement to control diabetes? Will it go up or will it come down?
It will come down, sir.
Why?
Because the insulin, the stimulation comes down. Like
stimulation, if it comes down, blood sugar has to go up. Insulin production is there. Insulin destruction or metabolism is there. Okay? Insulin production will be normal depending upon the blood sugar level. But the breakdown of insulin is reduced in CKD. So patients will have a prolonged effect of insulin. So their drug requirement will become lesser. In fact, many patients I have seen who were already on oral hypoglycemic agents and insulin prior to developing CKD, gradually they stop the insulin and maintain on very minimal oral anti-OHs because their blood sugars come down as they develop CKD. Okay. So these patients will have again an increased blood sugar if they are on peritoneal dialysis because of the higher glucose in the dialysate fluid, which will be absorbed, and they may restart on insulin. So that is a very important point that you have to remember.
Okay.
Okay. So this patient, supposing he has gone in for progressive CKD and he requires a renal replacement therapy in the form of renal transplant. Okay. So what are the types of transplant you know
of? We have a live donor transplant, deceased donor transplant, sir.
Very good. So what is the difference between a live donor and a deceased donor transplantation? What are the practical differences?
Deceased donor we usually taken from a cadaver, sir. And
brain dead. Don't say cadaver. The word cadaver is not to be used anymore. Okay, you have to use only a brain dead.
Brain dead patient. Yes. And
how do you define brain dead, brainstem death?
Brainstem death is defined as the irreversible functional impairment of the brain, which involves the brain stems and the respiratory centers will be hampered. And with ruling out all the other causes of decreased brain functions like hypoglycemia, the electrolyte imbalance, and hypothermia, and also.
Okay. So I'm sorry. What is the definition of brainstem death? You said irreversible unconsciousness and unconsciousness and inability to breathe on their own. These are the two things that you have to say as a definition of brain death. Okay. So do you know anything about brainstem death testing? How
Yes,
is
sir.
it tested?
Brainstem death usually tested. Two examination has to be done, sir, which is 6 hours apart, and the team should consist of a physician, anesthetist, and a neurophysician. And the test includes, first we have to see for the imaging modality, so which proves that there is some insult to the brain. Second, we'll have to assess the GCS of the patient. Third, we'll have to assess the patient's reflexes, which includes the pupillary reflexes, the pharyngeal reflexes, and the cold saline irrigation test also. Then the last comes to apnea test. So in apnea test, before doing, we have to confirm that patient has got a positive or a euvolemic status, and should be normothermic, more than 36.5, and the systolic blood pressure of more than 90 millimeter of mercury. And prior to doing the apnea test, we increase the PO2 level. We give 200% of oxygen. And
Okay, right.
yes.
So you seem to have read well about that. So your brain testing is positive, and the relatives are willing to donate the organ.
Okay, sir.
Patient is wheeled into the OT for organ retrieval.
Yes, sir.
How are you going to maintain? Do you have to give anesthesia for brain dead donor organ retrieval?
Yes, sir. Because
Why?
the spinal reflex will be intact, sir.
Okay.
And we'll have to give analgesia and the muscle relaxants also, sir. And then we have to maintain the hemodynamics also, sir, because for the perfusion of all the organs.
Okay. So what is the sequence of organ harvestation? Which organ is harvested first?
First will be heart, sir.
Heart and lungs.
Heart and lungs, followed by the liver, kidney, intestine, and skin and cornea, sir.
Kidney, liver. Okay. How long the kidney can be preserved? Supposing the brain dead donor, you harvest the kidneys, and the patient harvestation is taking place in Chennai, and you have to transport it to Madurai or Bombay for donation. How long can it be preserved in the refrigerator?
With the cold up to 4 degrees Celsius, we can preserve up to 24 hours.
36 to 40 hours.
Okay.
Not 24 hours, it's 36 to 40 hours. At the correct temperature, you can preserve that. Okay, right. So what are all the challenges you face in the brain dead donor recipient? Supposing a donor kidney is available from a brain dead patient, and your hospital gets an information that you have to do the transplant can be done. What are the challenges with the recipient anesthesia?
One is it is an emergency procedure, so they should be prepared, sir, for the procedure. And all the documentation should be done properly, sir, because according to the priority only they will be receiving the kidney. And third thing, the investigation has to be done. All the electrolytes has to be all the blood investigation has to be done, and they might require a dialysis prior to the procedures. And after the dialysis,
supposing there is only 4 hours time before surgery, and patient was dialyzed 2 days ago, and he is due for dialysis on that day. What type of dialysis you will give?
we can give an heparin-free dialysis, sir.
Heparin-free dialysis. How is that possible? When you don't inject heparin, will not the blood taken out from the patient clot in the circuits?
We can use
what is the mechanism? How do you say it is heparin-free dialysis?
Instead of heparin, we can give sodium citrate, sir.
No, that is an alternate for heparin. But when you use a heparin-free dialysis, without injecting the heparin into the recipient's body, how is the blood prevented from clotting? That is the question that you can ask. The circuits, the tubes which are drawing the blood and then pumping it back, they are all coated with the heparin inside. Okay? So it is a local action which is preventing the coagulation. That is how the heparin-free dialysis works.
Okay.
Right. So, a quick emergency, which particular investigation is very important after doing the dialysis, heparin-free dialysis?
The coagulation parameter and the electrolytes will be doing, sir.
Potassium, mainly potassium.
Yes.
Because hyperkalemia is very important. What is the composition of this preservative fluid which can cause a problem intraoperatively?
The preservative fluids we usually use the urocolin solution or the University of Wisconsin solutions or a HTK solution, sir. So
what is their main composition which can cause some problem in the recipient after anastomosis and clamp release?
Usually have a buffer, sir. and it can have the energy supplying that like an adenosine or a glucose.
They have high potassium also.
High potassium, yes.
All the preservative solutions have got a high potassium, so that when they are flushed back into the patient, the recipient after anastomosis, patient can develop sudden hyperacute hyperkalemia. Okay, so that is a very important problem that you have to be aware of. And what other challenge you will face after the anastomosis of the kidney? Will the kidney secrete urine immediately in brain dead donor transplantation?
No, sir. We'll have to give diuretics, sir. Like usually mannitol or for mannitol, usually we'll be starting with mannitol.
Okay.
We can use furosemide, sir.
What is the indication or what are the advantages of using mannitol?
Mannitol, it has got, it's a diuretic, sir. Along with that, it has got
osmotic diuretic.
Osmotic
diuretic.
Yes,
Okay.
and it's antioxidant properties also, sir. So the kidney can be saved from the free radical injury, sir.
Okay, right. So this will you, if you don't get urine on the table after a cadaver or if the brain dead donor transplantation, what do you do? How long you have to wait? Sometimes for after a brain dead donor transplant, if you don't see brisk urine output on the table, how long will it take for the kidney to start its function?
Sorry, sir.
It may take up to 1 week sometimes. So the patient have to go back on his original dialysis till the time. Okay? So 2 or 3 cycles of hemodialysis may be required until the transplanted kidney starts working, which is not there in the live donor transplantation. Normally in live donor transplantation, 99% of the time you will see urine output on the table.
Yes.
Because what is cold ischemia and what is warm ischemia?
So the ischemia time is the time which starts with the clamping of the artery and the veins, so right from the donor, and it ends up with the anastomosis of the vessels in the recipient, sir. So warm ischemia time, it starts with the clamping of the vessels from the donor till the kidney is kept in the ice packs.
Till it is perfused with the cold perfusate, not just keeping in the ice alone is not effective. You have to perfuse with the kidney and flush out all the blood in the donor kidney. It has to become white. When you take it out, it will be pink with all the blood inside the vessel. So you have to flush it through the renal artery and then try to flush out all the blood so that it completely gets evacuated. Otherwise, all this blood will clot inside and it will not prevent the perfusion happening after the anastomosis. So that is why you wash it out, so that perfusate fluid also contains some heparin to prevent any clotting happening inside. Okay. So that is the time. That time you start the what is the temperature of the perfusate fluid? It is 4 degrees centigrade.
4 degrees, yes, sir.
And it is kept in a ice flash also to prevent warming up from the exterior, and that is the time what is called the starting of cold ischemia time. When you start the perfusion with cold saline or cold perfusing fluid, it is called cold ischemia, and then till it is re-anastomosed in the recipient and then normal blood starts flowing, that is the time called the cold ischemia time. The shorter the cold ischemia, better the results. So the surgeons try to finish that anastomosis as far as possible. Which are all the vessels that are taken for anastomosis in the recipient? You have to attach the renal artery and renal vein to the recipient blood vessels. Which blood vessels are normally dissected and anastomosis is done, and what are the types of anastomosis you know of? This anastomose to the external iliac artery and external iliac vein. Sometimes the surgeons may prefer to, if this is done, external iliac artery and veins are chosen, it is end to side anastomosis. The renal artery will be attached to the external iliac artery and vein from end to side. Whereas if internal iliac artery is taken, it will be sacrificed and it can do an end-to-end anastomosis. You can directly anastomose. The end-to-end anastomosis has got a better perfusion rate compared to end-to-side anastomosis. And the second reason why the internal iliac is chosen is you will not compromise with the lower limb perfusion if you take the internal iliac.
Okay.
Otherwise, by taking external iliac, you do some compromise of the blood supply to the concerned lower limb. Usually it is done on the right side. So post-operative, you must palpate the dorsalis pedis blood vessel and then see whether the lower limb perfusion is normally taking place or not. Especially in chronic diabetic patients, there may be atherosclerotic and the limb may be in a compromised state. So this surgical procedure is also of concern to you, because otherwise you may the patient may be brought back for exploration later on.
Okay.
So these are the points that you have to remember with regard to live donor transplantation. And in live donor transplantation, both the surgeries go on simultaneously. The donor surgery as well as the recipient surgery happen at the same time. Whereas in a deceased donor transplant, there is a gap. The donor is operated elsewhere at a different time, and the recipient procedure goes on at a different time. So that is the difference, main difference. And what are all the post-op complications? Sometimes the patient after successful renal transplant on the day one, sometimes may be brought back during the post-operative course also. What are all the complications, surgical complications for which you may require to anesthetize the patient again?
There can be a graft rejection can happen. So it can be an acute or delayed graft rejection, sir.
Okay.
And
acute graft rejection is on the table, and you may land up with a graft nephrectomy immediately.
Yes.
That is during the course of the first surgery itself.
Yeah.
But my question is, what are all the, after you have completed the surgery, there is a good urine output, patient is wheeled out. After 2 or 3 days, they may bring back the patient. For what reasons they may require an exploration again?
Like any hematoma or anything?
Very good. Hematoma or ureteric leak. The most common complication is the anastomosis of the ureter done to the bladder sometimes gives way, and the urine starts extravasating into the retroperitoneal area. So they may require a re-exploration and do a re-anastomosis of the patient. So in that situation, when the patient comes back for a re-explorative surgery in the immediate post-op period, in what way the recipient is a slightly more challenging patient compared to the first surgery?
One thing, the electrolytes and all, we'll have to check, sir, all the blood parameters.
No, kidney is now working well. Urine output is good. Only thing, it's a mechanical problem. Urine is not draining into the bladder, but it is going into the retroperitoneal area and coming out through the drain. So the volume-wise, electrolyte status-wise is be normal. But what do they do to prevent a rejection?
They'll give immunosuppressant, sir.
So patient will be on a heavy dose of immunosuppression. So what can happen if you are not careful?
If they are on cyclosporin, that can potentiate the neuromuscular agents, sir.
Very good.
And if they may be in
First and foremost, they are more susceptible to infection or not?
Yes, sir. Yes, sir.
So all the aseptic technique should be very, very meticulous. You cannot afford to be lax in your asepsis, otherwise they can develop a severe sepsis, and then you can go for any infection, especially lung infection. Post-operative cytomegalovirus infection is very, very common. Second anesthesia, second intubation, they die of lung complications more than the renal complications. Okay, so you have to be very, very careful in these patients to make sure that every step is meticulously planned and all sterile precautions are followed to the maximum. Okay.
Okay.
Can you do a transplant in patients with different blood group?
Yes, sir. It was done, sir, before. How
is it done? What is the procedure you have to do before you select a patient with a different, for example, a group patient getting a kidney from a B group patient?
The HLA should be matched, sir.
No, that will not match. If you have a different blood group, it is, it is like a mismatched transfusion.
Yes.
But now they succeed in doing that by what is called plasmapheresis.
Okay.
Okay, because it's mainly an antigen antibody reaction. So they remove all the antibodies from the donor and then you can do the transplant. It's called plasmapheresis, incompatible blood donor.
Okay. Yes.
So that is also possible nowadays. And so these are the common questions. A patient with a CKD coming for incidental surgery or a transplant surgery, or sometimes they may land up for an emergency procedure. A CKD patient who is on a conservative management or on a renal replacement therapy, by meeting with a trauma or an emergency acute gallbladder or appendix infection requiring emergency surgery. These are the three types of patients you may get.
Okay.
So we are almost nearing the time. So Kalpana, can I go ahead and show my screen to them?
Yes, sir. You are now the host, sir.
Okay, thank you. So are you able to see my slides?
Yes,
Yes,
sir.
sir.
Okay. So this common thing what you have to remember in your exam, the definition of CKD is very, very important. So they may start only with this particular question. How do you define progressive, means chronic kidney disease? It is a progressive irreversible deterioration of renal function. And it is defined by the GFR only. The GFR is the main criteria for defining whether it is normal function or a deteriorating function. And based on the GFR, you have the grading of stage 1, stage 2, stage 3, and stage 4. And or it can be a damage to the kidney structure leading to a decrease in GFR. And whether it is natural decrease or a damage GFR decrease, it should have been there for more than 3 months. That is a very important criteria to call it chronic. And when there is a kidney damage, it can be manifested as abnormalities in the composition of blood or urine. And that's why I asked all the questions about the urine specific gravity, the contents, the cast, and all that. And it may be changes in radiological imaging or ultrasonogram, where it will show the difference in the cortical and the medullary blood supply. Or it can take a biopsy. Young patients suddenly developing chronic kidney disease, usually it is IgA nephropathy. So to establish the diagnosis, you may need a kidney biopsy. So histologically or by blood composition or by radiological, all these things also are the reasons for CKD with the damage in the structure of the kidney. And the common etiology is very, very common. Most common in our population is diabetic nephropathy. The second commonest is hypertensive nephropathy, or there may be glomerulonephritis, or it may be renovascular, bilateral renal artery stenosis, or polycystic kidney, or reflux nephropathy, or congenital renal diseases, interstitial nephritis, especially NSAID induced, and HIV or transplant failure, chronic rejection. All these things are the causes for CKD. When you take the history, you must find out whether there is a gradual decrease in urine output. If you ask them, he will say, yes, I have been passing normal urine. Of late, I am passing only once or twice about 100 to 200 ml of urine. Then the second will be, a very common thing is loss of appetite, nausea and vomiting. Majority of the times, the diagnosis itself is made when patients come with nausea and vomiting, not relieved by the normal antiemetics and IV fluids. When you check the blood sugar, blood urea, it is somewhere around 100, 120. Then you go for further investigation, you find them, they are having CKD. So the main presenting symptom will be nausea and vomiting in some cases. And third thing, patients who develop hypertension, it is advisable, if the hypertension is very severe, it is always better to rule out the secondary causes of hypertension and then look for any evidence of CKD in those patients. Or they may have uncontrolled diabetes mellitus for a long number of years. that also whether the patient has been adhering to the treatment and following the diet restrictions, or has he been going around with uncontrolled sugar values for a long time. It's very important history. And then they may be having swelling in the eyelid in the morning, which disappears later in the day, or a pedal edema. And they may have breathlessness on exertion, maybe because of the hypertension or fluid overload. And there may be bleeding episodes, especially GI tract bleeding in the form of hematemesis or melena, or they may have sudden epistaxis due to high BP, or they may have any intracerebral bleeding also as an acute episode. Then insomnia and irritability. These patients, because of the high urea level, they may have insomnia and irritability. And again, urea can cause severe pruritus. And in this pruritus, if the scratch marks contain blood, that indicates that there is a platelet dysfunction also in these patients. And any problems, if they have already initiated on renal replacement therapy, they may complain of disequilibrium disorders because of the dialysis or not able to tolerate hemodialysis. All these problems will be mentioned as a complaint. And when you ask for the duration and severity of the comorbidity like hypertension, diabetes, or urological problems, and patients with musculoskeletal problems like rheumatoid arthritis or chronic osteoarthritis, they abuse or take these NSAIDs for a long time. So it is very, very important to ask for this history. And to this, you must also add any native medication treatment. Some patients, as soon as they develop some mild diagnosis of renal impairment, they go to they see the advertisements in the TV and other things, go to the people who prescribe herbal medications and other things, which worsen the condition, and they land up late with frank CKD. And if the patient is already on renal replacement, first of all, ask them what was the indication, whether it was done for high creatinine level or a severe acidosis, or whether they landed up with a pulmonary edema and required dialysis. So first find out what is the indication and whether it was initiated as an emergency or an elective after creating an AV fistula. That is another thing to show the urgency with which they needed the renal replacement therapy. Whether any hemodynamic instability was there during the start of this renal replacement. Then frequency of dialysis required, whether they are having it twice a week or thrice a week, and how much of weight gain they have in between dialysis, and any history of pulmonary edema because they skipped one dialysis, they went for a function or went abroad, had no time to have the regular dialysis. So such procedures, such skipping the dialysis produced any overload and caused pulmonary edema. That is a very important issue because those candidates will be very high risk candidates if you are not careful with your intraoperative fluid management. Then how much of native urine passes? The case presented by Dr. Anish, he says the patient has still been passing normal urine. If that is the case, you are lucky. Your patient will have a good urine output on the table and you can be more liberal with the fluid that you give. On the contrary, if the patient has got very little urine output, the nephrologists usually restrict the fluid intake to 500 to 750 ml per day, including all the liquid dietary preparations also. So apart from plain water, all the liquid preparations total will be only 500 to 750. So that history is also very, very important. Then when you examine the patient, look for any facial or eyelid edema, pedal edema. They may be having frank anemia. Look for scratch marks for bleeding and measure all the vitals. When systemic examination, look for any evidence of congestive failure in the form of elevated neck veins, pedal edema, or look for the heart size, which may be enlarged because of either a pericardial effusion or it can be because of cardiomyopathy also. And uremic cardiomyopathy is also one of the complications in a long-standing CKD patient. In the respiratory system, watch out for the respiratory rate and any fluid signs, mild basal cramps present all the time, indicate both fluid overload and the heart's inability to pump the fluid. In the abdomen, look for any renal angle tenderness and swelling, because patients with polycystic kidney will have a definite renal angle swelling, or they may have enlarged bladder because of obstruction due to, especially male patients with a chronic enlarged prostate may have an enlarged bladder, or there may be free fluid in the abdomen also. And with CNS, they may have sensory and motor neuropathy, and autonomic neuropathy is very common even in non-diabetic patients with CKD. And if they have AV fistula, look at the site functional status. By just touching the AV fistula, you can feel the thrill and see whether there is a complication of gigantism, whether the fingers and the palm have become more in size compared to the other side, which is called local gigantism. That may be a complication. And the investigations that are commonly done are CBC for rule out or they assess the status of hemoglobin, WBC to find out whether there is any occult infection, and platelet function. Nowadays we have a platelet assay, and platelet distribution width is also assessed, which is the early indicator of platelet dysfunction. And regarding renal function test, urea creatinine ratio, urine microscopic examination, culture and sensitivity are important to rule out any underlying urinary infection. X-ray test for ruling out pericarditis or cardiomyopathy, and whether any fluid or effusion in the lung can be detected. And normally, chronic uncontrolled hypertension in these patients leads to left ventricular hypertrophy. There may be features of hyperkalemia like tall T wave and prolonged URS complex, or there may be silent MI, especially in chronic diabetic mellitus patient. They might have suffered an MI because they don't feel pain. There may be ECG changes accordingly. With regard to echo, you have to do assess the cardiac function. Both the ejection fraction as well as the diastolic dysfunction is also very, very important. And you must assess the size, pulmonary pressures, and whether there are any pericardial fluid in the pericardial sac. USG abdomen is done both for renal parenchymal assessment. Usually you find the corticomedullary dissociation or differentiation is lost. That means the less blood supply is going to the cortex, and it will be almost equal to the medullary blood flow. So that is what is called the corticomedullary dissociation. And the bladder in chronic CKD patients who are on renal replacement therapy like dialysis for a number of years, because there is no urine secreted into the urinary bladder, the bladder becomes very shrunken. That is called the thimble bladder. Sometimes patients with 5 years, 6 years of dialysis, when they come for a transplant, their bladder will not be able to hold the large volume of urine that is secreted after transplant. So you may need to first dilate and expand that bladder before you take up the patient for surgery. So from that angle, the bladder size also has to be assessed. And if the patients are male patients, you have to assess the prostate size also, so that they don't develop any post-op renal retention. And the electrolytes, it is not only the sodium and chloride, but all the electrolytes, potassium, phosphate, magnesium, calcium, bicarbonate, all the 7 electrolytes have to be assessed, and the values have to be taken into consideration according to the level. And ABG will show the degree of acidosis and the correction. If the pH is within normal limit, that means it's a well compensated acidosis. On the contrary, if the pH is not within normal range, that means there is an acute element, so you have to be quite careful. And the anion gap also has to be assessed. And in preparing the patient, anemia correction can be done by oral supplementation as well as parenteral iron, and you can use the erythropoietin preparations which are available, and proper control of blood pressure and diabetic medications. As I told earlier, chronic diabetic patients require lesser medication if they develop CKD. So they have to alter the drug dosage or skip some drugs so that they don't land up in hypoglycemia. And nutrition, they have to receive adequate protein to keep the muscle mass. Otherwise, they lose the muscle mass and become more cachectic. And phosphate restriction is very, very important because this is the one which is going to interfere with the calcium metabolism. And if they are on renal replacement therapy, you must do adequate dialysis either through IJV in emergency cases, or you have to use AV fistula or peritoneal dialysis in patients who don't tolerate hemodialysis. Coming to anesthetic management, usually you can do it under GA for surgeries which require general anesthesia, and the NPO for 6 hours for elective surgeries. Within 24 hours hemodialysis if the patient is already on renal replacement. Always have a watch on the potassium, continue with the antihypertensives, except ACEs and ARBs, skip OHA, and you have to give adequate aspiration prophylaxis with pantoprazole or proton pump inhibitors and antacids. Anxiolytics can be given, and immunosuppressive therapy in case patient comes for transplant. And intraoperatively, as a blanket rule, avoid all drugs which are eliminated by the kidney. And change in pharmacodynamics will happen in the form of increase in the volume of distribution and decrease in protein binding. So the volume of distribution increase will require more dosage, but the protein binding decrease will adjust with that. So more or less you can use the normal dosage that you have planned for the body weight. And induction agent, the choice will be between propofol, thiopentone and etomidate. And relaxants, you can use Saxa in case of normal potassium values and an anticipated difficult airway, you can definitely use Saxa. But if the airway is manageable, it is always safer to go for atracurium or cisatracurium to avoid the risk of hyperkalemia after Saxa. Analgesics, you can use fentanyl safely, avoid morphine and pethidine. And inhalation agents, isoflurane or sevoflurane will be the choice. And reversal, titrate your neostigmine. Don't give the full dose because it is renally excreted and you will have a delayed bradycardia, and even cardiac arrest have happened because of the standard 2.5 milligram given as a routine for all the patients. And the points to remember are avoid BP cuff and IV line on the fistula limb. Fluids, use normal dose in patients who have sufficient native urine output like the case presented, or patients who do not have any gross edema, you can use the normal dose. Restrict the fluid in those with very poor output. If the native urine output is less than 200, you have to be very, very careful in giving the intraoperative fluid, both for non-transplant surgery as well as in transplant surgery until the anastomosis and clamp release. Maximum safely you can use only up to 1 to 1.5 liters. Avoid potassium containing IV fluids as far as possible, but too much of normal saline also to be avoided because it will produce hyperchloremic metabolic acidosis. Half normal saline can be given to reduce the sodium load, and when the clamp release is done in the recipient after vascular anastomosis, there are chances of sudden hypotension or arrhythmia. So you have to be very, very watchful during that stage. And what are all the types of patients with established chronic kidney disease you may get in your practice? The first category is what like Dr. Anish presented, moderate CKD, but not on any renal replacement therapy, but treated conservatively. They may be posted for incidental surgery, the classical case what he described today. And the second category is the ESRT patients who have already on hemodialysis, who are coming for a renal replacement or a transplant or an incidental surgery. For example, an ESRT patient on dialysis, if he already has a hernia, if he requires a surgery, do the hernia repair before transplant, you can do it safely. And the ESRD patients who are on peritoneal dialysis also, sometimes they can come for either a non-transplant or a transplant surgery. Even they come for transplant, the intraperitoneal catheter has to be first removed and then you have to proceed with the surgery. And the peritoneal dialysis should be stopped at least 3 hours prior to the planned surgery. That is the only criteria that you have to take into consideration. And as I said earlier, peritoneal dialysis patients will have a high blood sugar level because of the dialysate. So you have to give adequate doses of insulin to make them normoglycemic. And any of these above patients, that is patients who are on conservative management or patients who are already on renal replacement therapy, may come for emergency surgical procedures like trauma or acute abdomen or obstetric emergencies. So in that case, the simple principle is be careful with your fluid, be careful with your prevention of infection, and be ready for any emergency dialysis in the immediate intra or post-operative period. These are the 3 basic things you have to remember. And final category of patient is patients who are after transplant coming for complications or a surgery later. I had one patient who had a hemorrhoids. He did not reveal it before surgery, and surgeon also did not notice it. But after 4 months of transplant, the hemorrhoids became quite severe and he required a hemorrhoidectomy. So like that, incidental surgeries can happen in patients who had a transplant. But as long as their renal function is well maintained, you can treat them like normal patients, except for looking into their immunosuppression regimen and make sure that no infection is possible because of careless or negligent attitude towards asepsis. Now, ESRD patients already on renal replacement therapy, coming for renal transplantation. So what are all the management that you have to do is, the types of renal transplant, it can be live related donor transplantation or live unrelated donor transplantation. So the first category is own kith and kin, father, mother, brother, sister, like that. Or it can be a friend, neighbor, or an emotional donor. And or it can be a deceased heart beating donor, like a brain dead patient, who trauma patient on ventilator in ICU, donating the organ. And nowadays, because of lack of availability of donors, they also do what is called non-heart beating donors. So some patients, they give an acceptance or give ready to donate organ after their death. They communicate and register themselves. In that patient, if they are admitted in the hospital and suddenly they develop a cardiac arrest and their heart stops, you can harvest the organs even if the heart is not beating. Then you can do incompatible blood group and paired exchange program. And in compatible blood group donor, incompatible blood group, you can do it after plasmapheresis. Now the questions which you have to anticipate in the practical exam, because when the same case is given to all the students, the examiners will feel bored to ask the same questions, or sometimes they may feel that the candidates may go out and leak the questions to the next student. So they try to change the questions and ask different types of questions. So these are all the topics from which you can expect questions. One is the physiology of urine formation, which I asked Anish, and then the mechanisms of concentration of the urine by countercurrent exchange and multiplication. They may sometimes ask the histological structure and functions of the nephron. They can ask you about the endocrine functions of the kidney. They can ask you all about the diuretics and their pharmacology, and the role of kidney in maintaining the homeostasis or acid-base metabolism, how it is done. And you can sometimes ask about how to maintain renal function during vascular surgery in the form of aortic cross-clamping, suprarenal and infrarenal aortic cross-clamping. And they can ask you suddenly all about acute kidney injury instead of CKD. They can ask you what are all the causes, how you classify, what is rifle criteria, what is AKI criteria, what are the biomarkers for acute kidney injury. So questions may be totally on acute kidney injury, even though you get a patient with CKD as a case for you. And sometimes they may drill you with this brainstem death testing. And lastly, they can ask you all the details about types of renal replacement therapy also. Okay, so that is what I wanted to just sum up and tell you. So that completes, I think, our discussion.
So there is a question in the chat box. May I read it, sir?
Yeah, please.
If a patient has come with CKD, should we give regional or no? As a platelet function is hampered, then what should we answer in the exam?
Very good. The answer is if it is renal, the coagulation profile is normal, then there is no contraindication for patients who are on renal replacement therapy to undergo a regional technique. So the main criteria is you have to test the bleeding time, clotting time. Nowadays with the thromboelastography, we can very well assess the coagulation status at the bedside. And if the bleeding coagulation profile is normal, and if the surgery warrants, for example, a fractured both bones leg in a trauma patient with CKD, if you can maintain, if the problem comes when the CKD patient is on a renal replacement therapy, you are absolutely safe, because even if you give a little extra fluid, it can be immediately removed post-op by doing a dialysis. Whereas if the patient is having is not on renal replacement therapy, he is a CKD patient with moderate stage 3 or stage 4, then you have to be careful with your intraoperative fluid, maintain the pressure of the GFR by adequate fluids and vasoactive support, so that you don't precipitate an acute kidney injury in that patient. Otherwise, if the bleeding profile is, coagulation profile is normal, there is no contraindication for regional in any infraumbilical surgeries like hernia, hydrocele, hemorrhoids, or trauma, or even labor you can do under regional.
So I don't see any more questions. I'm
I
really
think somebody asked for, can you repeat the ACE and the ARB?
Yes.
Actually, someone has put it in the chat box. Again, for their benefit, I will say ACEs and ARBs in the early stages of renal damage. It is the problem occurs mainly because the basement membrane is not able to hold the proteins which are prevented by to come into the glomerular Bowman space in normal kidney. Okay, so in those patients, the damage is indicated by the filtration of protein into the filtrate. It comes along with the 180 ml of filtrate that comes into the Bowman space and goes into the proximal tubule. So during the early stages, if the microalbuminuria is less than 30 milligrams per day, then in that stage, the ACEs and the ARBs try to strengthen this basement membrane and prevent the rapid deterioration of the kidney function. On the contrary, if the proteinuria has already crossed more than 300 milligrams, that in that case, this renovascular adaptation, because the ACEs and the ARBs, they try to control the pressure in the afferent and efferent arterioles for the filtration fraction. So that gets worsened and the kidney function deteriorates faster. So late stages of CKD or the kidney involvement, you should not use ACE in the ARBs. Only in the early stages, it will just like modulation of the cardiac muscles in the AC and the ARBs when you give it for patients with cardiac problem. The same adaptation happens in the kidney also. Okay? So that is how the drug has to be very carefully used. And if the patient has no established kidney function, a diabetic with hypertension, the first choice is ACE or ARB. But if there is a proteinuria, no AIC and ARB in a diabetic.
I don't see any more questions, sir. I can just say one thing. As it is rightly said, 1 hour with a very good teacher is much better than spending 100 hours with your books. And I think today, sir, you did complete justice to this statement. I thank you so much for having had taken this exam for Anish and set up a standard for all our students. I think they all loved it. I'm seeing some answers coming in the chat box, and they're really very happy with the presentation, sir. So would you like to make any comments about Anish? Anything more that he can do to improve, and any more tips to our residents, sir?
First thing, I want to congratulate Hanish because he is very bold and he has a good clarity in his concept, and he is able to boldly present that. That is a very good sign that of a very good student who has understood the subject properly. And second thing is, as a mark of little advice, what I would like to say him is, you answer a little slowly and wait for the examiner to probe you more rather than rapidly going on with. See, with regard to brainstem testing, when I asked him, he started completely going in like a Vande Bharat. He was slightly going on and on. Instead of that, you slow down your pace a little bit, because in Viva you don't have to go elaborate like your theory examination and write or explain all the points that you want to say. So you can reduce that speed and then just say it a little slowly so that you can impress the examiner that you know that particular point, and then give them time to go from that to some other topic also. Otherwise, he was very good. He's very confident. I can see that he was not nervous or anything. So that is a very important quality all the students should develop. They should not have any fear in their mind when they go to the exam, and think calmly and take your time to answer. You will do very well.
Thanks, sir. Thanks a lot, sir.
Thank you, sir, very much for spending time with us. And I'm going to invite you some more on our webinar. And I would really appreciate if you accept it within your busy schedule of your teaching that you're already continuing, sir.
Definitely, it's my pleasure. Thank you very much. Thank you all for the opportunity. I hope I have some use to all of you.
Sir, you're being too humble. It was just phenomenal. Thank you so much, sir.
Somebody has put a question here. CVP during transplant for recipient and post-transplant. Yes, some centers do definitely use CVP as a guideline. But in my long practice of more than 25 years with my recipients, I hardly have used CVP both for monitoring as well as for fluid replacement only in about maximum 6 cases or so. Because my nephrologist felt that any invasion into the major vessels with the immunosuppression, they are more likely to develop any post-op complications or infections. So they are worried about that. So he never wanted a central line. He used to manage only the peripheral line. The only problem is if they do repeated blood investigations in the post-operative period, then it becomes a problem that every time they have to poke the patient to take the sample. If you have a central line, it becomes much more easier to take the sample and do the testing. But if the kidneys are working well and the urine output is quite good, then there is no need for such frequent testing also. Once a day, urea and creatinine, because I have seen patients with creatinine of 4.5, 5 and all that. If the kidneys are working well and in the first day, if you have about 15 liters of urine output, the very next morning, the creatinine comes to 1 milligram. Like, such a dramatic reduction will be there and clearance will be there. Only in those patients who gradually decrease their urea, say from 4.8 to second day of 3.5, then 2.5. Some patients take a little time to do that. In that patients, you have to do repeated testing. And my nephrologist, if the second day creatinine is 1 or less than 1, he will never test the urea and creatinine for the next until discharge, because he is so confident that kidney is working well, and he will just monitor the urine output and give the fluid. And the guideline for post-op fluid management is you have to give the previous hour's volume of urine plus 100 ml. That is the calculation that is used. If you use that, there is no need for CVP to be measured and maintain it between 5 and 8 centimeters and all that. So it depends on nephrologist to nephrologist. But some centers, especially corporates, they can make a little bit extra in the billing by doing a CVP line. That also happens. But in my opinion, I didn't see a need for a regular CVP insertion in all my patients.
Thank you so much, sir. Thank you,
Welcome.
everybody, for joining us today. Good night. Good night.
Thank you. Good night. Thank you.